This screencast is on schizophrenia and related disorders. So, a lot of you may have never encountered someone with schizophrenia, or you may be wondering if you've encountered someone with schizophrenia. I don't think there's any other psychiatric disorder that is as mysterious, misunderstood, and misrepresented as schizophrenia. And I think the media has a lot to do with that. I mean, it is a devastating disorder. It is chronic, lifelong, serious psychiatric illness. But the way that schizophrenia is often portrayed as maybe somebody with a bunch of different personalities or something like that is completely wrong. Now, others in the class probably have personal experience and they know someone with schizophrenia. And it's oftentimes a parent in the classroom who has had contact with somebody with schizophrenia. They usually have a better understanding and more compassion towards people that are affected by this psychiatric disorder. So today we'll talk about schizophrenia. We'll look at some videos. There will be additional videos posted in your course that you need to watch so you have a good, solid understanding of this disorder. The first thing that we want to look at in schizophrenia is the areas that are affected by the disorder. And the first area is the content of thought and the form of thought. Usually you will see disturbance in thought. Now, how can you tell what somebody is thinking? That's actually a pretty hard thing to do. I can't do it. If you know how to do that, please let me know. But nobody can read another person's mind. Even a fortune teller. That's not real. Nobody's psychic like that. They can't tell you what you're thinking. But by listening to someone talk, you can get a good indication of what that individual's thoughts are like. And when you speak with somebody with schizophrenia, typically, not always, but typically you can tell pretty quickly that their thinking is very different from yours and the average person. And we'll talk about that in just a second, which areas are typically affected or how those thought patterns are kind of different from normal ones. The next thing is perceptions. And so when we talk about perceptions, there's sensation and then perception, like you have your senses. But in schizophrenia, oftentimes you have alteration in perception. Now, a perception in the absence of a stimulus, so you perceive something, but there's no stimulus there, that is what a hallucination is. And hallucinations are very common in schizophrenia. So again, a hallucination is a sensory perception in the absence of a sensory stimuli. And you can have hallucinations in all of your senses. Auditory, which is the most common in schizophrenia, visual, tactile, gustatory, and olfactory. So all of your senses you can have hallucinations in. But in schizophrenia, auditory is the most common. Now, affect. Remember, affect is your emotional response to a particular stimulus. You will see alterations in affect. Sometimes individuals with schizophrenia's affect is totally inappropriate. Others might have a blunted or flat affect, and they really have no emotional response at all. You'll also see alterations in their sense of self. They might not feel like themselves. There can be lots of things. We'll talk about that in a little bit. Their motivation oftentimes is impaired, so they don't have motivation to do things like they once did. You might see behavior patterns that are odd, unique to that individual, sometimes repetitive or inappropriate. And then you'll see impairment in interpersonal functioning. So the first thing that I want to talk about with schizophrenia is a differentiation between positive symptoms and negative symptoms. Now think about the word. Positive means to add something. So think about like adding something to that individual that normally isn't there. So you put something on them. That's a good way to think about positive symptoms. So their thoughts, they might have delusions, which are false belief patterns that are rigidly held despite incontrovertible evidence to the contrary. So delusions. Do normal people have delusions? Not typically. So you add that on. A hallucination is also a positive symptom, but you might also have emotions and behaviors that are positive symptoms. Negative symptoms, on the other hand, means taking something away that's typically there. And this is really difficult for students to understand, but I want you to think about schizophrenia in a little different way, because often it's the negative symptoms that are most prevalent. Now, this poor guy right here, I just found this picture off of Google Images, but what's going on with him? You know, he's laying there, he doesn't look very clean. How's his motivation? Not good. His interpersonal skills? Not good. Hygiene? Probably not good. I mean, he's got dress shoes here and an umbrella, but, you know, he's sleeping on the street, on newspapers. And this is a very common presentation in schizophrenia. So, I mean, go to New York City, and you will see individuals like this all over the place. Go to San Francisco. And a lot of people think, oh, that, you know, look at that guy's just homeless. The homeless person. Unfortunately, a lot of times it's psychiatric illness. And these are the negative symptoms. So take something away that should be there that isn't. So the motivation goes. Social skills are gone. Personal hygiene is gone. When you remove things like that, that's what we like to talk about with the category of negative symptomology. Okay, so here we go. Symptoms: delusions, positive symptom. Hallucinations, positive symptom. And then disturbed speech or disturbed behavior can kind of go either way. And as we talk about those in a little more detail, you'll understand. So again, a delusion is a false belief system that is rigidly held despite incontrovertible evidence. You want an example of a delusion? Let's say, okay, I'll give you some real life examples from clients that I've seen in state hospital. So frequent one is that somebody or something is following them. The individual will report that satellites are tracking their behavior, or the CIA is following them, or the FBI is monitoring them. Now, sometimes you'll have an experience where something like that might be accurate. I saw a young man that was threatening to kill President Bush, and he was in fact contacted by the Secret Service. That was very real. So sometimes delusions seem real, sometimes they don't. I'm trying to think of other examples. Oh, one guy was delusional and thought that he owned the state hospital in South Florida. That was pretty interesting. He would always yell at the psychiatrist to turn the lights off because his electric bill was so high. That was kind of interesting. Another woman, she was overweight and had been for a long time. And when you asked her about her weight, she thought that she was pregnant with Jesus's baby. And so she would talk at length about carrying Jesus' child. And no matter what you said to her, she would still believe this. So you could say, like, listen, we've given you a pregnancy test, and the pregnancy test says no, you are not pregnant. And she said back something to the effect of, do you expect Jesus' baby to show up on an average pregnancy test? No, this is a divine child. And would go on and really, truly, truly believe this. That's a delusion. Now, again, hallucinations are a sensory experience in the absence of a stimulus. And auditory hallucinations are the most common in schizophrenia. So people will typically hear voices. And when you ask somebody about the voices they hear, I mean, I can't tell you how many people I've talked to about this that hear voices, and nobody ever says the voices are nice or friendly or anything like that. They always report that the hallucinations it's like a voice or multiple voices that they'll hear, and that they're highly, highly critical. And they'll say stuff like, you're worthless, you should die, something like that. And they hear this voice, just like you hear my voice right now. In a room, they'll hear the voice, clear as day, but obviously the person next to them doesn't hear it. So, sometimes I'll ask patients simply, do you ever see or hear things that other people don't see or hear? And that's a good way to elicit information about hallucinations. Disturbed speech is very interesting. That's a very prevalent symptom of schizophrenia. We have slides on that are coming up. Sometimes speech goes away and the person will be mute. Other times the language that comes out of their mouth is unrecognizable. So speech is involved. And then again, their behavior. Sometimes they'll have odd, eccentric, unique behavior or repetitive behavior, agitated behavior. Sometimes people with schizophrenia have a symptom that's called catatonia, where they will sit in a chair in one position and not move. Other times people with catatonia can be very, very energetic, almost hyperactive, but they'll repeat the same behavior over and over and over again. So these are the subcategory for the speech disorders. One thing is called word salad. Students often love that term. Word salad is when the words that are coming out of the individual's mouth are kind of all mixed up and jumbled around. I have a short video of a guy whose speech is like that. Sometimes it kind of makes more sense than other times. Sometimes it's really, really jumbled up. Sometimes it's kind of like strings of words that kind of go together, but you'll have a lot of trouble understanding what that individual is trying to say. Another symptom is echolalia. Echolalia. So look at echo. And what's an echo? Echo. 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 And it's when the individual repeats what you say. So you'll say, oh, hello, how are you? And they'll say, hello, how are you? And then you'll say, I'm doing fine. And they'll say back, I'm doing fine. And they repeat what you say. Sometimes kids play that game. It can get kind of obnoxious, but that's echolalia. And then clanging is another verbal presentation where the individual will speak, but it's kind of like, it's really interesting when you see it. It's like, kind of like a sing-songy, rhythmic, rhyming pattern to their language. And I wish I could do a good example of this, but it's, and this isn't a good example, but like, ting, tang, sing, sang, bing, bang, dang. And the individual will keep that up in their speech. Let's watch this video here.
The third type of symptom that may be present is disorganization of thought and speech.
So that the thoughts are disconnected, and when a person speaks, there is either a great deal of tangential, circumstantial, rambling kinds of lack of connectedness of one thought to the other.
Like in the daytime when I be outside in the sun, I used to show my friends things that they hadn't seen before, like the halo. See, like the halo, when I was 19, when I was preaching, I had my trial sermon, I used to see a little light on my shadow on the ground in the daytime. And then now, ever since then, there's the light coming further down over my body, around my shadow. It's over my body, but around my shadow, and I see the light, which is your halo, your aura.
Okay, so did you pay attention there with William? All right, so I don't know what he's talking about, but something about a halo and a light coming down on him and a shadow, and his thoughts are jumbled up, and the words that are coming out of his mouth are kind of jumbled up too. But I mean, he seems to really be trying to give you some information. But again, here, listen to the words that are coming out of his mouth.
Everybody can't see that, but if see, you got something to do with drugs too, we say, and now I don't know what for real. I know what I see, but I don't know for real or not. So that's why you say people are different. You see, like that anointing, like see, like sometimes when I come outside, I can see when I look at the trees, the wind starts blowing. But we know we get oxygen from the plants, and we get them carbon dioxide.
Okay, so what is going on here? Again, you can kind of understand what he's talking about, but he has this kind of loose association between his thoughts. They kind of jump around, and they're loosely connected. But again, when he's talking, his words are kind of coming out jumbled. That's a pretty typical presentation. Okay, let's talk about the different types of schizophrenia. So there's going to be different categories that we need to differentiate. So there's going to be the main categories here. We'll go through these, talk about these. The first one is catatonic type. So, I mean, know that. That's the first type of schizophrenia. And this is characterized by a variety of bodily movement abnormalities. And so, catatonia itself means an extreme motor disturbance in a psychiatric disorder not attributable to a physiological cause. You can have all sorts of neurological disorders that will look like catatonia, but this is specific to a psychiatric disorder. And I mean, someday we'll understand that there is a physiological cause to this. This is a disorder of the brain, but we just don't know what causes it. So if you go into a state hospital and you look at the patients with schizophrenia, they're going to look very different. And one category is going to be individuals that are catatonic. They're going to sit on a couch all day long. They might be in a wheelchair and they will not move. Sometimes they have like a repetitive behavior. So maybe they'll tap their feet or something like that. There's another type of catatonia called waxy flexibility. Now this sounds really weird, but you can do this once in a while. The individual, you can kind of pose them. You can bend their arm or, like move them around, and they'll get stuck in that position. Now, catatonia also can be like extreme hyperactivity, so it can present that way. Some people with schizophrenia will lay in bed all day long. It's actually, I mean, it's fascinating, but it's kind of scary to see this type of schizophrenia. The next type is a disorganized type. This is categorized by a combination of symptoms. So you'll see disorganized speech and behavior and flat or inappropriate affect. You'll also have delusions and hallucinations that lack a coherent theme. So that guy in the video that we saw, William, he'd probably be disorganized type. So he's got these delusions, maybe even a hallucination about the halo that he has, that he's trying to show his friends. But it's not like one particular theme. You can tell that his thoughts are kind of mixed up. The association between thoughts is kind of loose. You see that disorganized speech. That would be a good example of disorganized schizophrenia. sometimes you'll see individuals walking around and their clothes just will not be right for the situation. And they might look odd or bizarre. Oftentimes that's disorganized schizophrenia. Sometimes it's this next type called paranoid type, though. So paranoid type is the most frequent presentation, and this is characterized by preoccupations with one or more bizarre delusions, auditory hallucinations that are related to a particular theme of being persecuted or harassed, and paranoia is the primary symptom. So these individuals are going to talk about the same thing over and over and over and over again. So that it's kind of like they're stuck on this one theme. And it'll be associated with the delusion that they have. The delusion is going to be persecutory in nature, or that they're being harassed by somebody. Again, I told you about clients will typically think that the FBI, the CIA, the Secret Service, somebody is following them or out to get them. The government is monitoring their phone calls. Actually, now I want to stop and make note that, we just recently found out that the government is monitoring our phone calls. However, this is going to be a lot more than that. And it's a false belief. So you have to make sure that the belief that this individual has is false, and it can't be consistent with their culture also. So paranoid schizophrenia is very, very interesting. And then there's an undifferentiated type that's characterized by a complex of schizophrenic symptoms that doesn't meet criteria for the other types of disorders. And then the last one is a residual type, and this applies to people previously diagnosed as schizophrenic, if they no longer show prominent psychotic symptoms but show lingering signs of the disorder. Now, the way that we research shows, the course of schizophrenia is chronic and lifelong. So this diagnosis kind of bothers me. But, if you have a misdiagnosis of schizophrenia, think about that. If somebody has that diagnosis in their past and they still might have a symptom or two, they might be diagnosed with residual type for the rest of their lives. Just be cognizant of that. This video is a case study in schizophrenia. Let's watch a little bit of this. This individual's name is Heather.
What do you drink? What do you eat? Do you realize that I have a monopoly over the coffee industry? Okay, so that's the problem, isn't it? That's the complaint, right? Well, kryptonite. You know what that is, don't you? Kryptonite? And, so if I have kryptonite, I drink coffee and soda, and no one else knows what to eat. Do they have raw eggs? Do they have raw eggs? To eat raw eggs. When I was pregnant, I think boys get pregnant and girls don't. It's true. But I ate raw eggs. But, do you eat raw eggs? What do you eat and drink? That's a big problem. Do you know what to keep you sane by? Is that a complaint? No?
My daughter now is in a state hospital. We, like most families, have run out of funds after years of seeking help in all the private facilities. And there certainly is a vast difference between the private facility and the state hospital. These are not hospitals. These are institutions, some of them very much like prisons. When it comes time to take her back to the hospital, she's, reluctant to go back. And then I say to myself, is it possible? is it possible that I could keep her home?
Turn up shopping.
And then
You
I...
want to go turn up shopping? You want to go turn up shopping?
What kind of shopping?
Turn up shopping.
What is that?
What is that? I don't know turn up. How you do it off?
Oh, Heather, is it a soap?
Huh? Is turn up a soap? Turn up is a soap. Yeah.
Oh, and you want to buy some?
Here.
A special kind of soap? Oh, we'll stop on the break. You want to stop and get some? When we go back?
We're not going back.
Okay. Now, I know this video's old, but I like it. What type of schizophrenia do you think Heather has? Does she seem to be paranoid? I don't know. Maybe a little bit. Honestly, we don't really know. How about catatonic? No, she's not catatonic at all. What about residual? No, she's got some pretty predominant symptoms going on right now, so that doesn't fit. How about disorganized? Well, yeah, I think disorganized is probably the best bet here. I mean, this is a limited, sample of information, but she's kind of disorganized in her thinking. Now, I want you to put yourself into the shoes of Heather's mom. So Heather probably didn't have the onset of symptoms until she was maybe 20 years old. So she looks like she's about, 25, 30. So she would have been a, relatively normal child. I don't know what her childhood was like. She might have had some other problems, but she wouldn't have had schizophrenia. And this is like one of the hardest parts of schizophrenia, is that its onset is in young adulthood or late adolescence. And you see this radical decline in their functioning. And if you have ever had a friend with schizophrenia, if you knew them before and after, it's not the same person. So personally, I've had a couple friends from childhood that have schizophrenia. And unfortunately, they are really impaired by the disorder. And, it's not the same person. That is a serious disorder of the brain. I want you to think of it that way. And have compassion for that individual and that individual's family. Okay, so let's talk about the history of schizophrenia a little bit. Eugene Bleuler was the individual that coined the term schizophrenia. That'll definitely be on your final. The original term for schizophrenia was called dementia praecox by a guy named Emile Kraepelin. But Bleuler coined the term schizophrenia. So Bleuler and Kraepelin will likely be on your final. I want you to probably put that in your notes. Bleuler talked about the 4 fundamental features, which we still today call Bleuler's 4 A's. And it was the association, affect, ambivalence, and I want you to know autism here. And autism, really that term, do not think of it as autism, like the disorder as autism today, but this is kind of a turning into the self. Like auto means self, like AUTO, not like the car, but like in Latin, auto means self. Ism means like turning into the self. And what happens is that the individual withdraws from reality and social functioning. So that was a form of autism. There are other psychotic disorders, even depression. You can have depression with psychotic features. I personally have seen people with depression with psychotic features. When they get really, really depressed, they have a tendency to get psychotic. And it's more like delusions and hallucinations. But let's talk about some of the other psychotic disorders. and they're gonna be like schizophrenia, and they're gonna have the break with reality. Actually, we should talk about the word psychotic. The word psychotic, I want you to, when you hear that word, think that means delusions and or hallucinations. And this really comes out of old psychiatric tradition when they would use the term neurotic versus psychotic. And somebody that is neurotic or has neuroses, they're still in touch with reality, but they have some psychological problems. When somebody is psychotic or psychoses, that is the break with reality. And this can't be caused by cognitive impairment, and it can't be primarily affective, like mood. There's going to be similar symptoms like delusions, hallucinations, disorganized speech, and grossly disorganized or catatonic behavior. So very similar to schizophrenia. The first one is schizophreniform disorder. That word again, schizophreniform. And I like to think of this as like schizophrenia is forming. That's how you can remember that. Schizophreniform disorder is essentially the same as schizophrenia, but it only lasts from 1 to 6 months. So schizophrenia, you need to have the symptoms for at least 6 months. Schizoaffective disorder. Schizoaffective disorder. And this is schizophrenia with a co-occurring mood disorder. The diagnosis of schizoaffective disorder, in my opinion, has been on the rise. In the psychiatric hospital that I worked in, I would see individuals diagnosed with schizoaffective disorder all the time. But I gotta tell you, I mean, like, okay, let's say you have schizophrenia and you're locked up in a state hospital and somebody tells you you have schizophrenia. How are you gonna feel? Frankly, I'd be really, really, really depressed. So, I don't know. There's other problems with the schizoaffective diagnosis. Just be aware of that. Delusional disorders are really interesting. I wish we went into these a little more, but we don't have time. Delusional disorders are characterized by delusions. And there's 5 main categories of this. First one is erotomatic. This has to do with love. And so the individual will, for example, believe that a celebrity is in love with them, or that a celebrity is their one true love. If only they could meet them, they would fall madly in love. People that stalk celebrities oftentimes have erotomatic delusions. Grandiose is like grandiosity in their delusion. So individuals will think they are a reincarnation of Napoleon or Jesus, or that they're going to be the next president of the United States. I've seen people that have claimed that they own like giant record companies, and one guy told me that he signed Michael Jackson to all of his contracts, and he was Michael Jackson's manager. That's delusional, and that's grandiose. Jealous delusions, actually, these are a little scary. And if you turn on like Maury Povich or one of the daytime television shows like that, sometimes Jerry Springer, well, Jerry's not a very good example. Maury is the best. But sometimes you'll have guys or girls on there that are just obsessed that their significant other is cheating on them. And the significant other will come on and say, like, I don't know what's going on. This is ridiculous. I work all day. I'm home all day. They're watching me. They're monitoring me. Like, he found a receipt from the grocery store and is convinced that I was on a date with somebody else. And that's a jealous delusion. Not always, but I mean, that's what the presentation is like. So the individual always thinks the other person is cheating, or it can be their boss, or somebody at work is conspiring against them, or something like that. Actually, that what I just said, somebody at work conspiring against them, that would be more persecutory. If they were jealous of the treatment of somebody else at work by the boss, but it was not realistic. Again, delusional means it's a false belief. That would be jealous. Persecutory would be like somebody's out to get them. They're conspiring against them. You know, again, that could be the FBI or the CIA, or satellites are monitoring their movements. Somatic is really interesting. People will have delusions about bodily functions and disorders. A lot of guys I've seen believe they have tracking devices that are implanted in them. I've even seen people that have ripped out their teeth because they were convinced that a dentist put a tracking chip in their tooth, and they could look in the mirror and see the cavity, and they thought that was a tracking chip. There's a famous case about a young man named Ralph Tortorici in New York State that shot up a classroom at a local college, and he believed that there was a tracking device in his penis, which is really interesting. Imagine you're a doctor and somebody comes in with that concern, and they would do x-rays and they put them in all sorts of, tests and stuff like that, and they'd say, Mr. Tortorici, you do not have a tracking device in you. And he just wouldn't believe it. That's what a delusion is like. Okay, shared psychotic disorder is delusional disorder in which one or more people develop a delusional system, and this is as a result of a close relationship with a psychotic person who is delusional. Sometimes another person will come to believe the delusion of that individual. That used to be called folie à deux, like a French phrase. There's lots of different theories as to the origin of these disorders. And, I mean, they are biological in nature. But the concordance rate, like if you have an identical twin with schizophrenia, you only have about a 50% chance of having schizophrenia yourself. So there's something strongly in the environment that influences the onset of the disorder. So yes, biological. What it is, we don't know. I mean, researchers are, desperately trying to find the cause of schizophrenia. And it'll probably be something genetic and then something environmental, and they'll interact, and then you'll see the expression of the disorder. There's probably several different genes involved. I mean, given the different presentations, you could have 5 people with schizophrenia in a room, and they look like they have totally different disorders. So it'll probably be a different combination of genes. We call those like candidate genes, again, and then something environmental that will trigger the disorder. So we can look at different brain structures. We can see ventricular enlargement. I should have put a picture of that, but enlarged ventricles and cortical atrophy, so the covering of the brain shrinks. You can see differences in diffusion tensor imaging. Another hypothesis is a dopamine hypothesis, that there's problems with regulation of dopamine systems in the brain. And a good analogy of schizophrenia, if you want to see what somebody with schizophrenia is like, have them smoke like methamphetamine or do cocaine for like 5 days straight. And you will see somebody get very, very, very psychotic. The drugs that block dopamine reduce the positive symptoms of schizophrenia. In a drug overdose, it can reduce the symptoms of hallucinations and delusions. But there's other neurotransmitter systems that are involved, like serotonin, all sorts of stuff. So we don't really know. The genetic abnormalities that are present are going to affect probably, lots and lots of different areas. So structure and function. That is the two main categories. So there's going to be impairment in brain development, likely, synaptic transmission of various neurotransmitters. There might even be dysregulation in immune functioning. Maybe it's the immune system that turns on the body and causes the atrophy in the cortex or something like that. There could be manufacturing of important proteins that are involved of neurotransmission that are affected. Maybe proteins are created that aren't supposed to be there, or they're misshapen, or they're deleted, something like that. And it might be a developmental process because, again, the individual is normal. And you won't see symptoms until late adolescence or early adulthood. So that might have something to do with it. There's lots of different treatments available. There's lots of drugs. There's two main categories of drugs. We call them typical antipsychotics or neuroleptics. And the book uses the term neuroleptic, but you could also call them antipsychotics. So typical or first generation, that was the first set of drugs that came out. And then we call them atypical or second generation drugs. The distinction isn't that useful anymore. I mean, the idea was the atypical or second generation had less side effects from the first generation, but they still have lots of side effects too. And the drugs for schizophrenia, the antipsychotic drugs, are very powerful medications. They first came out in about the 1950s. The first drug was chlorpromazine or Thorazine. And, I mean, radically, think about that. Since that time, I mean, those drugs have not been out for a long time, but have radically changed the face of the treatment of psychiatric disorders in general. So one of the things that we have to look out for are the side effects of these drugs. One is called extrapyramidal symptoms, or EPS, or tardive dyskinesias. And these are typically movement disorders. So if you remember, dopamine is involved in movement, and you can really see the side effects in movement. Let's watch this little video here.
You ever notice that you shake?
Yes. My thighs shake a lot, and my fingers shake a lot.
Watch right here.
The other problem is that they're often not able to supply history.
A little bit.
They often tolerate drug side effects because they've lived with them for 20
Look right here.
years. And I think they probably just shrug their shoulders and say, this is part of what's wrong with me. And plus, they've been treated for so long, and the development of these things may be so gradual that they don't perceive them. You take a drug, and all of a sudden your head twists like this. You know about it, you say it's the drug, very clearly identified. But you develop Parkinson's, which develops over days, weeks, or months. And people don't know it. They notice when they have a tremor. So if their hand's going like this, they'll say, oh yeah, I shake, it's from my medicines. But if they're like this, and they move slowly, their balance is a bit off, they won't recognize that. And frequently their doctors don't either. They all recognize the tremor. But beyond that, they frequently don't identify the other things, the stoop posture, the absence of arm swing, and the bradykinesia. Those often go unrecognized. Now, the right hand,
Here, watch this guy.
as facial masking.
Facial masking, like, look at the guy's face. He doesn't seem to have a lot of expression. Not this guy.
Frequently don't identify the other things, the stoop posture, the absence, and the facial masking.
Right there.
Hold it sideways now. There you go. He has diminished, he's not much older than me, and that would be normal. And the left hand, see, he's very, very bradykinetic.
This is a neurological exam that they're doing.
Up and down, the whole leg up and down. He's tapping his leg up and down, and he should be able to get a much, much higher amplitude and better speed than he's generating right now. So these are manifestations of his bradykinesia. Careful with your hand.
Look at his face.
Psychiatric patients can be visibly affected by their antipsychotic treatment.
Okay, so we'll stop there. There's lots of different side effects. There's dystonias where muscles will cramp. You know, people's heads might swing back. There can be ocular dystonias where their eyes might roll back in their head. There are all sorts of serious side effects that can occur with the drugs. Now, I mean, it's not in everybody, and the psychiatrist that prescribes the medication should be aware of these disorders, and with the right dosing and monitoring, you might not have problems with side effects at all, but a lot of people do. And one category of side effects we call pseudo-Parkinsonism, and that means fake Parkinson's disease. And by blocking dopamine with the drugs, you can mimic the symptoms of Parkinson's disease. So at the state hospital, you'll see 25-year-old guys shuffling around like they have Parkinson's disease. Here's another video. Let's watch this really quickly.
Try not to be distracted by the movements in her lower face. Please focus your attention on her eyebrows.
Okay, I want you to look at the symptoms of her lower face. See this facial grimacing? This should look weird to you. And if you saw somebody on the street like that, you would go, whoa, what's going on with that? But you can look at other parts of the face too, and these are movement disorders. See her tongue rolling around? And then her eyebrows go up, tongue's out. Okay, that's bad. And that's a good example of some of the movement disorders. But okay, so you've got this individual, maybe this, poor grandmother was hallucinating like ridiculous, scary hallucinations, and she was delusional and yelling and screaming. So do you take the movement disorders versus the hallucinations and delusions for quality of life? I don't know. I want you to think about that. Make a judgment on your own.
Body area to be scored. This segment features a rather subtle lip movement. Notice the sucking in the lower lip.
See that sucking in there? Her neck seems to be kind of jutted forward too. She's having some muscle movement problems there. Scary thing is that some of these movement disorders can be permanent. They're not just temporary while you're taking the drug. Okay, so from a psychological perspective, there is no pure psychological origin of the disorder. So don't think of it that way, but think about the psychological impacts of the disorder. Somebody has some serious problems in their social cognition. Their brains actually become less activated when given social cognition tasks. Individuals with schizophrenia have difficulty in working on people-oriented jobs. It really becomes difficult for them to maintain employment. And a lot of people with schizophrenia turn to substance abuse. So high rates in substance abuse. When I was at the hospital, like somebody would become stabilized to the point where they would be released from the hospital. They would go out, they'd get their hands on some crack cocaine, smoke crack, and then they would have like a full-blown relapse in their psychotic symptoms, and they'd be back in a couple days. But, in some ways, the medication really dampens your feelings of pleasure, and one quick way to get over that is to smoke some crack cocaine. So, it's just a vicious cycle. It's unfortunate, but you can work on these psychological problems in therapy. However, there's no amount of psychotherapy is going to cure schizophrenia. We can use psychological techniques for interventions like token economies, cognitive behavioral therapy, and cognitive training to help the individual with schizophrenia. And I really recommend that. However, it's not going to cure the disorder. But we need to focus on the family, because really oftentimes it's the family that is having the hardest time with adjusting to the disorder. The impact can be harder on the family. You can target faulty modes of behavior and communication. Cognitive distortions can be addressed. You can talk about a high degree of expressed emotion in the family. You want to keep that low. Social class and income is a real issue for a lot of individuals with schizophrenia. And you want to address associated environmental stressors like poverty and contracting the disease. I don't like that term. That's out of the book. But when you get schizophrenia, there's a huge downward drift in social and economic functioning. Now, like somebody like John Nash, I bet you've seen the movie A Beautiful Mind. And you don't see it there in the movie unless you look carefully. Look at his social relationships, and you can see that downward drift. You think, oh, John Nash, super popular. Oh, everybody knows him. He's functioning great socially. No, that's not true. There is that downward drift, and with psychological interventions, social interventions, social workers, you can try to help prevent the impact of that downward drift. There are assertive community treatment programs where you get a team of professionals that work together. I like this the best as an option for individuals with schizophrenia, because you need psychiatric, psychological, nursing, and social work professionals to help that individual, because they're impacted in every area of their life. So they're going to need medications, and they're going to need a good psychiatrist to appropriately prescribe medications and monitor side effects. You're going to need the help of a psychologist to help them manage some of the symptoms of their disorders, work with their family, stuff like that. Nursing is very important, because oftentimes there's a whole host of medical problems that come about with schizophrenia. Plus, the individual might have problems with like hygiene and stuff like that. Nursing can help with that. Social workers can help them with, again, like those problems with employment and housing and poverty, things like that. So the more professionals that are on board to help that individual in their day-to-day life, the better. And again, this is a brain disorder, so we want to focus on those theories that talk about disruption in underlying brain mechanisms as being the problem for these cognitive deficits. So again, schizophrenia, disorder of the brain. It's a disease of the brain. And we really want to treat that individual as though they have a disease that is as serious as cancer or diabetes or any medical condition, because it's coming from an organ. It just happens to be that elusive organ, the brain, that we don't really understand. So we want those individuals to receive integrated care to maximize their chances of recovery. So that is schizophrenia in a nutshell. We could talk about this for hours and hours and hours and hours, but unfortunately I've limited this one to 1 hour. So if you have any questions or concerns, there's lots of information out there that's available. Read your textbook. Let me know if you have any questions at any point in time.